So a lot of people actually, a lot of individuals with the MS complain of poor sleep, probably about at least half, okay? And probably the most common complaint is fatigue, which is often related with sleep disorders. So sleep disorders, sleep medicine in general has become a pretty hot field, in that I think it's just being more and more recognized. So its association with a lot of other medical problems is being more and more recognized, okay? So the importance is that it can affect quality of life. In MS, it can actually exacerbate other associated symptoms, for example, depression or pain. And with some sleep disorders, there can be associated health risks, so that's important in and of itself. So causes of fatigue and poor sleep in MS. So it's not just sleep disorders alone. That's what I'm going to focus on today. But you have to keep in mind there are a lot of other things. So oftentimes people come in and they say, I'm here, I have fatigue, but I have MS. So, you know, a lot of people with MS chalk up their fatigue to the MS. Well, that's fine and everything. Certainly you can have fatigue. We do know, this is well known, is you can have fatigue with MS. This is not well understood at all, perhaps something to do with structural changes in the central nervous system. But it's really important to think about other causes of fatigue, because if we can modify anything that can lessen the fatigue, well then it's not just fatigue secondary to MS and we can't help you, right? So there are, of course, MS-related symptoms that affect sleep, so pain, spasms in the legs and so on, just trouble with mobility and getting up to pee at night. Depression and anxiety are often associated with MS, and these, a lot of the symptoms with sleep disorders and fatigue and so on actually overlap with depression, for example, so it's important to identify that. And a lot of medications used in MS can cause side effects of fatigue and sleepiness and disrupt sleep. So, for example, drugs used for spasticity or anxiety or depression can cause side effects. Immunotherapy itself, for example, interferons can cause insomnia as well as drowsiness, so you can have different effects. So sometimes changing the dose from nighttime dose to a morning dose may be helpful. So I'm going to, as I mentioned, focus on sleep disorders here tonight. And this is the classification of sleep disorders. Insomnia is probably the most common, and actually the most common sleep disorders in MS are insomnia and restless leg syndrome. So I'll definitely talk about those. But I'm also going to touch on other things like circadian rhythm disorders, sleep apnea, and hypersomnias of central origin, which includes narcolepsy, as well as some behaviors which occur in sleep, so parasomnias. So insomnia. So this is pretty common. The prevalence is over 40%. So insomnia is trouble either falling asleep or staying asleep. So either disrupted sleep or waking up early in the morning. And you have to have an associated daytime functional problem. So fatigue, cognitive issues like memory issues and so on, or altered mood. So you can't, if you just have poor sleep but you have no problems during the day, then it's not really insomnia. So there are a lot of different types of insomnia. So when we see people for this reason, we really need to iron out, what's the cause of the insomnia, because there are a lot of issues. I would say the most common reason is inadequate sleep hygiene. A lot of people, for example, spend too much time in bed. That's a big thing. A lot of people think that if they can't sleep, they should spend more time in bed to try to catch up on that sleep, but that's actually the worst thing you can do. So we actually do a lot of time in bed restriction as a method of treatment. So that's really important. The timings, keeping the sleep times regular, avoiding caffeine late or alcohol late and things like that. So there's a whole slew of things. Another thing is psychophysiologic insomnia. That's when you can't sleep because you're worrying about sleep or frustrated that you can't sleep. That makes it harder to sleep. So we try to remove that from the bed. And mental health disorders, for example, depression, of course, can affect sleep. Drugs or substances, as mentioned, some medical conditions such as MS, causing symptoms which disrupt sleep. Paradoxic insomnia is when you actually have a misperception and you think you're not sleeping well, but you are. Acute insomnia is typically related to a stressor. And idiopathic insomnia means we don't know why you have insomnia, which actually I don't think I've ever diagnosed. There's always a reason. Okay, so the mainstay of treatment for insomnia is really cognitive behavioral therapy, and we actually have we have people who do this within our Capital Health District, just at the Abbey Lane. We have a psychologist who does this for insomnia specifically. So this is a series of behavioral treatments. So really, really detailed evaluation and treatment. You don't need to go there to be treated, and you can read about a lot of this stuff online, or I do some of this as well. So now it's really loud all of a sudden. So sedative hypnotics. So medications. Okay, so really loud. Okay, so medications for insomnia, believe it or not, I don't use, okay? I'm a sleep specialist. I do not use sleep aids for insomnia. It's hard to believe because I get a lot of them on the medications and then I take them off. The problem with sleep aids is that although they may work in the short term, they don't tend to work in the long term. So, you're better off just implementing the behavioral strategies. Okay, so moving on now to circadian rhythm disorders. This is a problem with misalignment of your internal clock and the external light-dark clock and other cues. So basically, you're sleeping at the wrong times. So the most common one, for example, is delayed sleep phase syndrome. So these are people who cannot fall asleep and then have really a lot of trouble getting up in the morning and can't get up for work or school. But the trend is that sort of on the weekends when they don't have to work, they will stay up later and sleep in later. So you end up basically kind of being asleep when you're, at work in the morning. This is very common, especially common in teenagers, but certainly we see lots of it. So this can be very a big cause of impairment, and some people just cannot work because of it. And I've seen people drop out of school because of it. So young, children, teenagers. Okay, so it's a big problem. And actually, in multiple sclerosis, there may be a mechanism that increases your risk for circadian phase disorders, in that if you have demyelination of the pathways to and from our main pacemaker, the suprachiasmatic nucleus, then it can affect your rhythm. So for example, you may not produce as much melatonin as you should to make you sleepy at the right times. So this is the array of circadian phase disorders. So you can have delayed sleep phase. Advanced sleep phase is the opposite problem, where you fall asleep really early and you get up really early. So elderly folks have more of this kind of rhythm. Irregular sleep-wake rhythm, that's when you kind of sleep in chunks all over the place. That happens a lot for a lot of reasons, but in the blind, for example, as well as free running, is you're kind of moving around the clock. You don't have a 24-hour rhythm. Jet lag can be a problem, especially people who travel a lot, and shift workers. Yeah, so there are some studies indicating that circadian rhythm disorders are more frequent in MS, and perhaps that's because of the demyelination in the pathways involved. These folks tend to have more severe fatigue. So the treatment, we just basically, if you have delayed sleep phase, we'll advance the bedtimes, and we do it slowly. You don't want to do it rapidly, because that may make things worse. We'll gradually advance the wake times, bedtimes will fall into place. You need a lot of light, because that's what we respond to, is light. So you need lots of light in the morning, and sometimes we use light therapy, so light boxes. And melatonin is helpful a little bit, just adjunctively. And as mentioned, there may be a problem with melatonin secretion in MS. Reduced levels, and actually interferons can increase, so there's a lot of complicated factors in MS. Okay, moving on. So sleep-related movement disorders. So as I mentioned, restless leg syndrome is one of the most common sleep disorders in MS, and then I'm going to talk about periodic limb movement disorder as well. So restless leg syndrome, there are 4 criteria, okay? You need to have the urge to move the legs, and it's relieved by moving the legs, or partially relieved by moving the legs, and it has to be worse in the evening or nighttime compared with the day, okay? And you need all those criteria to have a diagnosis. So it's a clinical diagnosis. It's actually quite a lot more common in MS than in the general population, up to 6 times as common. And it tends to progress, but pretty slowly. So keep in mind, not everything is restless legs. So there are a lot of symptoms in MS which are not restless legs. So cramps, for example, in the legs, just pains, paresthesias. So you really need all those criteria. We don't understand the mechanism very well. There seems to be a familial preponderance. And for sure we know there's some kind of problem in dopamine pathways, because restless legs responds beautifully to dopamine agonist, dopamine medications. So medications used in Parkinson's disease, little tiny doses. And also there's a problem with iron metabolism, because sometimes getting the iron levels up is helpful. So, and actually there may be also a connection between iron deficiency and MS, because iron may play a role in myelination in MS, so maybe sort of low iron and then restless legs has some kind of connection. Restless legs is more common in pregnancy, probably again because of low iron, and kidney disease, end-stage renal disease, and peripheral neuropathies. So the problem with restless legs, the reason people treat them is really bothers them. It can be very severe, debilitating, or it affects sleep onset. Okay, so then you have the daytime fatigue and sleepiness even. In MS, some studies have shown that it tends to be more common in older age, when folks have a higher degree of disability, and if there's cervical lesions, which we don't really understand. So you could, in an MS patient, you could consider doing a cervical spine MRI if they haven't had it, to see if there's a lesion there. Especially if it's acute, you could treat that. And then in primary progressive MS, it's more common. So the treatment, as I mentioned, number 1 is dopamine agonist, very small doses in the evening. We also use a lot of gabapentin or pregabalins and Neurontin or Lyrica, which also is nice for sort of comorbid pain or anxiety in MS, so I use that quite a bit. And if those don't work, rarely we need to go to opioids. And sometimes benzos are helpful, not as much, but if you're using them for other reasons, it may be sufficient. You supplement iron and you avoid things like caffeine and alcohol and nicotine, which may precipitate them. And then it's important to know a lot of medications can precipitate restless legs. So most of the antidepressants, the only one that doesn't is Wellbutrin or bupropion. But of course, not in everybody are those medications going to cause restless legs or make them worse. But it's important to think about that. Okay, periodic limb movement disorder. So 80% of people with restless legs have periodic limb movements during sleep. Now, the inverse is not true, so if you have periodic limb movements of sleep, you don't necessarily have restless legs. But these are repetitive movements during sleep of your legs, mostly your legs. And by the way, the same goes for restless legs. Just because it's restless legs doesn't mean it's just involving the legs. It's primarily involving the legs. It starts with the legs, but it can certainly involve the arms or the rest of the body, okay? So anyway, periodic limb movements. You need to diagnose them with polysomnography. So I don't know if you can see here, but let's see if I can show you on an arrow. These are leg movements that occur repetitively. So if you have leg movements, you wouldn't know it. Your partner might know it if you have a partner. But this can make you very tired or sleepy. So that's called periodic limb movement disorder when you have like daytime symptoms associated with it. So some people have leg movements and they don't have daytime symptoms. Okay, so as well, more common in MS, so it makes sense because there's a connection there. I saw some studies about lesions in the brainstem and cerebellum being associated with restless legs and periodic limb movements. We don't really understand that. It's not really understood whether it's even a peripheral nervous system issue or central nervous system issue, so questionable significance. Okay, I think I'm talking a lot, 7:05. Okay, so I'm going to move on to sleep apnea. It's really important, very, very common in the general population. So there's obstructive sleep apnea, when your airway collapses, when your airway is crowded, especially if there's a large neck circumference with obesity or just crowding from setback jaw or excess tissue in the back of the throat. More common in older people, more common in men, but women, same as men after menopause. Central sleep apnea is when you're not initiating the breaths to begin with, and hypoventilation as well, when you're not initiating the breaths. So the importance is mostly people come in with fatigue or sleepiness, and then sleepiness can be severe while driving and conversations and so on, okay? You can have impaired cognitive function and mood changes. And there are serious health risks, so arrhythmias, high blood pressure, heart disease, stroke, increasing glucose, and so on, lots of them. So really important to diagnose. And this, like I said, in general, is going to be, if you have a problem with your sleep, you're most likely to have either sleep apnea or insomnia. But in MS, sort of the insomnia and restless legs are most common. So maybe in MS, obstructive sleep apnea can be more prominent because of, in some patients, significant disability to the point that they gain weight, so overweight, and maybe being on some medications like clonazepam, which can relax the airway. And in central sleep apnea, this has been found to be correlated with lesions in the brainstem, which affect the control of your respirations. So again, consider doing imaging at that time if someone presents with sort of an acute onset of central sleep apnea, because maybe high-dose steroids for a few days may be helpful. So the mainstay of treatment for sleep apnea is CPAP. So CPAP's continuous positive airway pressure. A lot of you probably have heard about it. A lot of people are on this. This is basically a device that compresses air, pumps the air to your airway through a mask. You use it when you sleep. It works beautifully. And people love it because they feel great. Okay. Weight loss is helpful, usually not curative. If you can't tolerate CPAP, there are other options like getting a dental device to pull your jaw forward, or jaw surgery to cut the upper and lower jaw and pull it forward. And if you have, as mentioned, central sleep apnea due to brainstem plaque in MS, just 5 days of high-dose steroids or something may be helpful there. So moving on, so narcolepsy. This is a disorder of excessive daytime sleepiness. You do not need to have any other symptom to have narcolepsy. So a lot of people don't know that. You can just have excessive daytime sleepiness, but the sleepiness is quite severe. Usually, you need to nap. You need to sleep. You just can't control the urge. And the naps tend to be refreshing. You don't have to have sleep attacks, though. You can just be sleepy. And you can have cataplexy, or you don't necessarily have to have cataplexy. Cataplexy is when you lose muscle tone with an emotional trigger. And the emotional trigger is usually actually a happy trigger, like if someone tells you a joke. So someone tells you a joke, you fall to the ground. That's cataplexy. It doesn't have to be that severe. It can be, very subtle, like a facial droop, or, droop of, just extremities or something. Like, it can be very subtle, but it can be very severe. So it can be debilitating. Other features of narcolepsy, you can hallucinate as you're falling asleep or as you're waking up. And these hallucinations are usually quite scary, so involve like insects, like spiders and things crawling over you, very uncomfortable. And then a lot of the times that's associated with sleep paralysis, so that means you can't move. So you have these things crawling all over you and you can't move for a couple minutes. So they can be quite scary. And by the way, they do happen in normal, healthy individuals. You don't have to have narcolepsy to have sleep paralysis or hallucinations as you're falling asleep. So it's some kind of problem with going in and out of REM sleep, kind of between REM and wakefulness. So it's interesting. And a lot of people with narcolepsy have sleep disruption. Okay, so we don't understand why narcolepsy happens. There's a lot of different hypotheses. There is a neuropeptide called hypocretin, which is an alerting hormone which seems to be deficient in narcolepsy. Especially with cataplexy, low histamine levels. I'm not going to get into all this stuff, but there's some kind of genetic component, but it's very complex because in some families it's common, in some families it's, very sporadic. So, and there seems to be an immune mechanism. There's an association with a haplotype, immune haplotype, which also is seen more commonly in MS, so maybe the connection there. There's some kind of immune connection. However, you have to be careful because these haplotypes are also seen in healthy individuals, okay, without these disorders. Secondary narcolepsy can be due to an MS lesion in the hypothalamus, so that they say that's the fourth most common cause according to this study. So there are actually criteria to diagnose narcolepsy. I'm not going to get into them, but we do basically an overnight sleep study at the lab, and then we bring patients in for nap opportunities the next day, see how quickly they fall asleep. If they fall asleep quickly, that's abnormal. And if they go into REM sleep, because it's a problem with regulation of your REM sleep, then that's diagnostic. And then without cataplexy, you definitely need this test to diagnose it. Okay, so treatment. Well, sleep hygiene, good sleep hygiene is good for any sleep disorder, but sometimes scheduled naps are very helpful. So people at their lunch break just have to have a nap, and we have to accommodate that. We give things to improve alertness, which some of you may have heard of because it's used. Modafinil or Alertec is used a lot in MS for MS-related fatigue. So definitely this is the #1 treatment also for narcolepsy, sleepiness associated with narcolepsy, as well as other stimulants, but modafinil has fewer side effects. Sodium oxybate or gamma hydroxybutyrate, this is known as the date rape drug. This works really well for narcolepsy. It's dispensed at a central pharmacy. It's very controlled. It basically puts you in a really deep sleep, and somehow it leaves you refreshed in the daytime, and it's great for the cataplexy too. So it's a good drug. Things to suppress REM, improve the cataplexy. So most antidepressants will suppress REM. So that's what we use. And again, just as I talked about with some of the other sleep disorders, if you have an acute onset of narcolepsy, there have been cases of this. It may be the presenting symptom of MS. You can have a lesion in the hypothalamus. So you can present, with narcolepsy as your first sort of attack of MS, and that can be treated with high-dose steroids. Okay, I think this is the last thing I'm going to talk about. So REM behavior disorder This is a parasomnia. So this is a disorder related to a behavior that happens in sleep. So basically what happens is people have violent, unpleasant dreams, usually fighting, chasing, just not nice dreams. Out. Okay, normally in REM sleep, you can't move, right? So these people are able to move. So what they'll do is they'll punch, they'll kick, and they can hurt themselves, they can hurt their partners. It can become a legal issue. It's a big problem. Yeah, I mean, it may be as simple as talking, but more so, just, if you're talking, it's not a big deal. A lot of people sleep talk, but if you are like punching things, it's a problem. Because of the worry about injury. So this is what it looks like on the sleep study. This is your REM sleep. These are rapid eye movements, and you're supposed to have nice, pretty flat hair, and this is increased tone, so that's abnormal. So a lot of the times we don't know what causes this. It happens mostly in men, mostly middle-aged men, but we know that there's an association with neurodegenerative disorders, especially Parkinson's disease and such disorders. And in fact, REM behavior disorder can precede Parkinson's by decades even. So, and in MS, the prevalence is 1.4%. So, it can happen. I mean, it can happen to anyone. So, important to recognize you don't want to hurt yourself or hurt your partners in sleep. So if you're doing this, it's important to get it evaluated. And again, MS attacks can present as REM behavior disorder. So if you have a lesion in your brainstem, it can present as this. Or it can happen as a flare or a later attack. So most important thing is to maintain a safe environment. I've had people break lamps, break mirrors, need lots of, really hurt themselves. So important to get rid of all that stuff, sharp edges, sharp objects, padding around the floors, things like that. And you may need to sleep apart from your bed partner. Avoiding precipitants, so another one here, like antidepressants, SSRIs, SNRIs, tricyclics, they can increase motor activity, so they can make this worse. Clonazepam is very effective for this, and melatonin can be used adjunctively. And again, in MS, if a brainstem lesion is causing this, you can treat it with high-dose steroids. Okay, so I'm going to conclude here by just telling you again, and most importantly, take-home message is fatigue in MS is not always just due to MS. So if there's any indication of a potential sleep disorder, then it's worthwhile exploring. And, especially if there's no bed partner, you just wouldn't know. So it's worth it, and you wouldn't waste anyone's time to think about it. Could there be a sleep disorder that's making me tired, okay? Because the sleep disorders are common in MS as they are in the general population, but some are more common in MS, as you've heard. The lesions in multiple sclerosis can lead to dysregulation of the sleep. So in that way, cause the sleep disorders. So consider the full spectrum of sleep disorders, and I've only mentioned some of the sleep disorders, sort of the kind of main important ones. And, if there is a sleep disorder, institute treatment. The treatment can improve quality of life quite significantly, as well as reduce some of the MS-related symptoms. For example, not just the fatigue and, the pain, things like that, depression, depressive symptoms. So it can be very helpful. And then some of these sleep disorders have serious health risks, so it's important to recognize for that reason. So thank you very much.